Hi everyone. I am Eva Naidenova, and I am going to present the PTSD chapter, which is chapter 7 in our book today. I'm doing a Zoom recording, basically to present it, but I also wanted to kind of share with you guys the PowerPoint of the presentation. It's more than like 69 slides. It's about 70 slides. So sometimes it's easier to just kind of read the slides versus just kind of listening to me talk. You guys don't need to read the book though. I feel like you can basically look at the PowerPoint, you can listen to my lecture if you want to, and kind of go from there. So I'm gonna do this like I do my online classes, for better or worse. But if you guys have any questions, something doesn't make sense during the presentation, please feel free to email me. So I'm gonna share my PowerPoint, which is what I always do. And I'm gonna basically present it. Let's see if this works as well as I think it does. Okay. So hopefully you guys can see this. That's always one of my worries whenever I present something, that it's not truly showing. But anyways, this is chapter 7. It's PTSD. It is the longest chapter in the book. Believe me, I checked. It is about 50 pages. I kind of went back and forth about how to present it, but I think again, it will be most beneficial to you guys if I just go and follow the format of the book, and kind of present the information there and add some additional information. So this is the first topic presentation that we have, of all of them. And the authors basically make the point that that is not random. They mean to start by discussing PTSD, post-traumatic stress disorder. And the reasons for that is that many other crises are rooted in PTSD. For example, it says in the book that suicide, substance abuse may be the result of attempting to cope with trauma. And we all know that sometimes people self-medicate. A lot of times they cannot deal with it themselves. And in contrast, rape, assault, loss, physical violence, and natural disasters may actually precipitate the disorder. And I'm going to talk about this. There was a very interesting book that I read about rape and sexual assault. The author makes a very, very kind of compelling point, that basically 100% of rapes result in PTSD. But again, we're going to talk about that later. The thing about PTSD is it's a very, very complex disorder. It can turn into a trans crisis. Um, I'm sorry, I'm sick, so my voice hopefully will hold throughout this presentation. So you guys probably are reviewing for the midterm at this point. You know what a trans crisis is. Basically a type of crisis that keeps going on and on, different things kind of set it off throughout your life. And The other reason why the authors choose to start talking about the different topics with PTSD in particular, is because it can be very, very relevant to the profession of counseling, to all the helping professions. Because unfortunately, many in the helping professions may develop PTSD-like symptoms. Um, that will be particularly relevant for you guys. Like I already said, a lot of counselors may develop PTSD. And they specifically talk about compassion fatigue and vicarious traumatization. So a lot of times it's very, very difficult to kind of listen to his stories of trauma and try to remain tuned in, try to remain like empathetic. And that's kind of what compassion fatigue speaks to. And vicarious traumatization is again in the same vein. You guys are going to be in a profession where, depending on kind of the population that you choose to serve, you may hear a lot of really, 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 really kind of traumatic stories. I remember when I was a senior in college, I went to Limestone College, which doesn't exist anymore. It's in Gaffney. I'm sure you guys have heard of it. It just closed. Um, and I was trying to decide if I want to get my PhD in clinical psychology or social psychology. I was kind of like interested in both. And I remember, hmm, oops, it looks like my voice may not hold, so I'll keep going until I can. But I remember I went to do an internship in the basically psychiatrist's office in Gaffney. And I was a senior, I'm going there. And they let me sit in on a bunch of different counseling sessions, which was great. I got a lot of exposure, but obviously I didn't have any clinical skills at the time. I didn't know anything about anything. And I remember there was one lady who was repeatedly sexually assaulted by her father and her brothers. And she was talking about this. And I remember like doing my best just not to cry. Like literally, like that was the hardest thing I've ever had to listen to. And at some point, like the therapist actually left the room because he had to take a call. So they left me alone with this lady was telling this like horrible story, was crying. So I can see how vicarious traumatization can truly be a problem with PTSD. Again, I apologize for my voice. So we are going to talk about the background of PTSD now. And I'm going to put all of that stuff here. I really had a lot of fun with this chapter. Basically, Freud was the first person to really talk about trauma because remember, he was all about like the Victorian society and how a lot of like people and children were traumatized, especially women and children. Um, so he worked with hypnosis. Remember, he went to France and studied under Charcot, who is basically the first person to do hypnosis. Um, so Freud, despite his many, many, many failings, was actually very much interested in trauma and had some very, very wise things to say about it. He said that psychic trauma is the result of experiencing an acute, overwhelming threat in which disequilibrium occurs. So basically, what he's saying is something terrible happens to you, you experience some kind of threat, and it throws you off balance. So this is very similar to like parts of the modern day definition. So again, he was way ahead of his time. One of my favorite psychologists ever, Erickson. Eric Erickson's, remember, he did the stages of psychosexual development, starting with trust versus mistrust, depending on how your parents treat you, and going all the way until old age. So Eric Erickson also had kind of thoughts about trauma. He also kind of was interested in, he also wrote about it. So a quote that he had was that basically believed that trauma is a result of the individual's mind, which cannot answer the question why it occurred, the trauma. So a secure sense of what has been in the past and what should be in the present is lost. So here, kind of Erickson is touching upon the sense of like basically you're lost in time that trauma brings, which is also part of the modern day definition. So again, those great psychologists really were able to kind of verbalize what the parts of PTSD is, again, way before the definition was created. So some of the other things about it were immediate and vivid re-experiencing are often common of PTSD, hyperarousal, avoidance of reactions, basically are very common following a traumatic event. Very traumatic stress symptoms are common following a crisis event. However, most people are extremely resilient and will quickly return to a state of mental and physical homeostasis. So I wanted to put that here is because I'm going to talk so much about trauma in the next hour. It might seem like basically anytime we experience a traumatic event, we are destined to get PTSD. As you guys know from the previous classes, that is definitely not the case. Most people do not get it. We're surprisingly resilient as human beings. It actually is amazing. Um, and even when something really, really, really kind of horrible happens to you, a lot of times you can go back to your natural state, to homeostasis. But again, it depends on like many different things that I'm going to talk about throughout this chapter. So some of the other things that are mentioned in the book about the background of PTSD is one of my favorite symptoms or disorders when we talked about psychodiagnostics. And I know a lot of you guys are in that class right now, so I'm sure you can remember it. And that's acute stress disorder. We had to do role play. I always wanted to like do the role play with acute stress disorder because I feel like it's a really, really interesting disorder. So acute stress disorder is when symptoms continue for a period of 2 days to 1 month and have an onset within a month of the traumatic event. So it occurs very, very fast. And it's a very, very, very kind of serious disorder. It's full on. But the thing about acute stress disorder is it fizzles out pretty quickly as well. If ASD symptoms develop, they will typically diminish in 1 to 3 months. But the thing about it is a very serious disorder. It does need to be treated. Uh, and sometimes it can result in PTSD if it's not treated. There's also, of course, delayed PTSD. We're gonna talk about it more throughout the chapter. But sometimes people were like in straight up denial. Going back to Freud and all the different defense mechanisms he talked about, when reality becomes too overwhelming, when we can deal with basically what just happened to us. Sometimes we may employ defense mechanisms. We might use repression, basically straight up, no, don't think about what just happened, wipe it out of awareness. We might use denial or other things like that. So those defense mechanisms a lot of times may result in delayed PTSD, meaning that something horrible happens to you and you seem fine. You continue with your daily business, you don't talk about it, you pretend it never happened. But of course, unfortunately, whatever happened to you has not been dealt with. So eventually, again, it may result in delayed PTSD. The thing about PTSD is you need to integrate the trauma into conscious awareness and organize it as part of the past to avoid delayed PTSD. So that's like the biggest thing about it. You have to be able to integrate what happened to you into your narrative. If you cannot, basically, unfortunately, a lot of times you deal with PTSD symptoms. So historical antecedents of PTSD. That part of the chapter I had a lot of fun with. And it was stuff that I never even heard of. So it's very, very interesting to me. Apparently, whenever there was this like vast railway expansion in the United States, um, we all know the history. There were a lot of like railway train accidents, which is not surprising. Obviously, they were just kind of first kind of learning how to do everything. Probably not a lot of safety checks. But where this gets relevant is that sometimes people will kind of get in a railroad train accident. There will be survivors. So they will not be actually physically hurt, but all of a sudden, they might become immobilized, they might be kind of become handicapped, unable to move, they might become paraplegic, and that will be all based on like psychological symptoms. Again, they were physically okay. So it was so common that I actually developed a term for that. It was called railway spine for those railway accident survivors with no physical injuries. And apparently, insurance was a deal at that time too. I had no idea. But insurance companies did not recognize the term railway spine. That was more like what doctors use and kind of informally. And so they had to be told those folks had compensation neurosis. Um, and basically, that meant being immobilized because of some kind of psychological trauma because of a railway train accident. Then, of course, the history of trauma will not be complete unless we mention Freud. I already talked about that. He was all about that. Remember Freud, early 1900s, late 1800s, was very, very, very interested in why some people basically develop mental illness. In some ways, he was amazing. Mm, because he was the first person to really kind of encourage counseling and people to be treated instead of kind of like left in asylums. But on the other hand, obviously he didn't use the scientific method. He had no idea how to understand trauma. So what he did was go to France and study under Martin Charcot, who again was the main person who did hypnosis. And what Charcot did was he will go to like different like rich ladies' houses, and one rich lady will be like, I cannot move my arm. Like I was perfectly fine, there's no physical injury. But all of a sudden, like I cannot move my right arm, for example. And Sherko will do hypnosis session with her friends. I'm sure you guys have seen the movies. And lo and behold, she'll be able to move her arm. That thing was obviously not a real disease. It doesn't exist today. At the time, they call it hysteria or hysterical neurosis. Um, the thing about it was very kind of society based. So Victorian society was very, very, very conservative. And it was very, very, very sexist towards women, even more than today. So for example, if you're a woman, you cannot work. You cannot go outside the house unless you are with a chaperone. If you are from a very wealthy family and your father dies, the money will go to like your male cousin that you might have never seen, not to you. So again, especially wealthy women during this period had nothing to do. They basically were sitting at home, playing the piano, doing embroidery. So this hysteria became very, very kind of popular. And it was a way for them to kind of work out the trauma of just being stuck at home and not treated as second-rate citizens, having no power over their own lives, but also a way for them to socialize and kind of host events. So that was obviously relevant to the history of trauma. And then we're going to come to traumatized combat veterans. That one is, I'm sure you guys very, very aware of. We're going to talk more about it throughout the next hour. There are very interesting terms for it that I never heard of it. For example, everybody has heard of shell shock. Everybody has heard of like combat fatigue, which is being on the front line too long. But I've never heard of soldier's heart. So basically, those are the same terms that they used at the time because they did not understand that being on the front lines can traumatize you, right? They believe that people who exhibited or veterans that exhibited PTSD symptoms after returning home were just kind of cowardly. They had physical injuries that they didn't realize, maybe some kind of head trauma. So there was no understanding initially up until the Vietnam War. We're going to talk about that of how PTSD can affect soldiers. And there's another term that I've never heard of, and that one is nostalgia. They use nostalgia as basically the equivalent of combat-induced PTSD, what we use nowadays. But basically, if a soldier had nostalgia, they will be told to like they're missing home, they're having all sorts of symptoms about not being able to adjust to being at war, etc. So other historical antecedents of PTSD, um, coming back to more modern times, again, late 60s, 1970s, really is the beginning of self-help groups. And those were not initially started by the government. Like I already said, there was a lot of misunderstanding about what soldiers go through. A lot of draftees, because remember at that point they had the draft. Everybody basically over 18 up to a certain age, with limited exceptions, had to go to war of the men. Basically, there was a lot of misunderstanding about what that war does to them, what being and fighting does to them. And also, the Vietnam War, as you guys know from all the historical documents and movies was deeply unpopular. So there were like all sorts of demonstrations in the United States against it. So whenever soldiers were coming back, not only were they traumatized sometimes maybe by being on the front lines, but also they were like basically welcomed with mistrust, with people telling them that they were baby killers, which is specifically talked about in the book, and things like this. So very, very, very much the public not approving of what they've done. So a bunch of different psychologists got together and decided to form their own self-help groups for returning veterans from the Vietnam War. And one of those psychologists, well, he's actually a psychiatrist, is Bessel van der Kolk, who's probably one of my favorite um, helping profession experts. He wrote the book, The Body Keeps the Score. Hopefully, you guys have read it. If you have not, please, I would highly recommend you to. I have a video about it. I'm going to keep talking about him. He's one of the most famous trauma specialists in not only in the United States, but in the world. As the book's name suggests, and as his name suggests, he's actually Dutch, but he has lived in the United States for a long time. Um, So him and a bunch of others started forming self-help groups, which kind of kickstarted the awareness of PTSD, and they eventually developed the definition and diagnostic criteria of PTSD. We're going to talk about in a second. And the other thing that happened was the recognition of domestic violence and rape via the women's movement. So that one, I don't know how much you guys know about it, but it really took a while. So as late as the 1980s and the 1990s, there were states that did not have laws against domestic violence. So the idea was if a guy was beating his wife, it's his wife, like there's nothing you can do about it. Um, there was the famous rule of thumb. So as long as he doesn't beat her with anything larger than his thumb, it's okay. You can beat your wife with something smaller. As you guys probably aware, North Carolina was the last state to enact the law against domestic violence. But even nowadays, if you've spoken to law enforcement, um, I've trained a lot of police officers for domestic violence situations, but a lot of them are deeply, deeply uncomfortable to go into somebody's house and kind of determine who's at fault, because a lot of times, like, both people are going at each other and kind of do something about it. So even nowadays, we're really not there yet. But in kind of late 80s, there was the battered women syndrome that was developed. Basically, the idea that women who are victims of domestic violence can develop PTSD. And many people kind of work really, really hard to get that done. I would love to talk to you guys more about it, as that is my area of expertise, romantic relationships and domestic violence in particular. But basically, all of that came together to be defined as post-traumatic stress disorder in the third edition of the American Psychiatric Association's Diagnostic and Statistical Manual. So until then, it was not a diagnosis. And like I said, my favorite person, Van der Kolk, spends like literally the first like 20 or 30 pages of his book talking about how hard it was to convince uh basically people that there is a diagnosis such as PTSD, that it needs to be included in the DSM. And he's still kind of fighting that battle. And it's kind of, to me, it's very surprising because I feel like at this point, we all recognize PTSD is a thing, right? We all recognize trauma affects people. But to kind of think back on a time where they did not realize that, like I said, to me is kind of fascinating. So going back to what is a PTSD, I'm gonna kind of try to pick up the speed here so I can fit within the hour that I was allotted. And everybody knows the diagnostic criteria of PTSD, right? I'm going to put it up here, talk about it briefly. My voice seems to have stabilized, so I want to get to like the meat of the chapter before it starts cracking again. But there's different diagnostic criteria for PTSD. You can all find them in our beloved DSM that hopefully every single person has by now. Our wonderful professor was so nice to kind of email us an electronic version. You can get it through the Gardner Web Library, or you can get that little chunk of love and kind of carry it around. I have one at home and one in my office because I do not want to carry it around. So, what does it take to get PTSD? It is exposure to an actual or threatened trauma. So obviously death, actual or threatened will qualify. Serious injury. The authors of our book, they talk about a serious injury that they had that actually gave them PTSD. Again, and sexual violence. Again, sexual assault, rape. Every state has a different definition of what rape is. So sexual violence is kind of like the more generic term. So the exposure it must include one of the following. So it has to be direct or witnessed. It doesn't necessarily have to happen to you. You can just witness it. Or it can happen to somebody that you deeply care about, right? It can be indirect. So somebody went and hurt my sister, and she keeps talking about it, and she's kind of like, I'm helping her live through it. That can give me PTSD. Um, Unfortunately, the fourth kind of diagnostic criterion is repeated or extreme indirect vicarious exposure of professionals. And kind of going back to the example that I gave you guys earlier, with me listening to that lady talk about her repeated sexual abuse and how that can really, 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 really be traumatic to hear. Um, that can obviously happen to any kind of health professional. They specifically make a point in our book and in the DSM-5 to say that observing a traumatic situation on TV does not meet the criteria unless it is work related. So basically watching like a bunch of Dexter on TV might like really gross you out, but it won't give you PTSD. So then there's criterion B, persistent re-experiencing of the trauma in at least one of the following ways. So it has to be recurrent, intrusive, and involuntary memories of the trauma, or recurrent traumatic nightmares, which might lead to self-medicating. We're going to talk about that again. There's a guy that is mentioned in the chapter in detail. He talks about like basically what his life is like with PTSD. He's a returning Vietnam vet. He has terrible, terrible, terrible nightmares to the point where he doesn't want to sleep. And when you can't sleep, when you're afraid to sleep, obviously you're tired all the time. He started drinking, so he can't sleep, kind of pass out, which obviously doesn't help his symptoms. So it can be kind of like a terrible, terrible thing to deal with. Then there's flashback episodes or dissociative episodes that range from brief episodes to loss of consciousness. Um, I've met many rape survivors in different shelters, in different situations where they basically describe that. And to me, that was kind of like one of the more interesting symptoms that sometimes they would like literally feel like they pass out, lose consciousness. Um, After like thinking about the trauma when re-experiencing the trauma. Then it could be intense or prolonged psychological distress after being exposed to stimuli that spark reminders of the traumatic event, such as panic attacks, anxiety, excessive and obsessive worry, and concern. So that will speak to things like maybe you're a Vietnam vet with PTSD. You have this like really, really traumatic memories of gunfights and like people shooting at you and you shooting at like other people. So every time a car backfires, you like have a panic attack. That's kind of what that speaks to. And then physiological reactions to events that symbolize the trauma. So the example they give in the book is a person who has PTSD after a tornado starts to shake violently at every approaching storm. So again, there's the avoidance criterion, a C, and basically you have to have one of these methods. You either should avoid thoughts or feelings connected to a traumatic event, and again, people usually do talk about this because they feel like that is the best way for them to get over the trauma is by avoiding it, or avoid people or situations connected to a traumatic event. But again, obviously, that is not the way to help yourself and kind of deal with your PTSD. Then there is negative changes in thoughts and mood, which in the DSM 5TR is known as criterion D. So those are negative alterations in mood and cognitions experienced in at least two ways. Inability to recall key features of the event, persistent negative cognitive distortions about self or the world, kind of saying things like, I am a bad person. Persistent distorted blame for the event, experiencing persistent trauma-related negative emotions such as anger, fear, sadness, guilt, and shame. Reduced interest in pre-traumatic activities such as hobbies, work, etc. Subjective alienation from significant others, constricted affect, and inability to experience positive emotions. So again, also something you can easily see in people who have PTSD. A lot of times they simply have trouble relating to the people they used to be close to. They feel they don't understand them. They seem unable to experience happiness. They feel like they did something to kind of bring this on themselves, and so forth and so on. There's also altered arousal and reactivity, which is criterion E in the DSM-5 TR. So you have the client has to have at least two of the following to be diagnosed. So they have to be show some kind of irritability or aggression. self-destructive or reckless behavior. Again, going back to the Vietnam vet who is discussed in the book, he really, really, really kind of in detail describes how sometimes he just wants to feel something other than this traumatic response. So he will put themselves in like really, really, really bad situations. He describes like baiting the police, so knowing that they're gonna chase him and hurt him and put him in jail, and things like that. Hypervigilance is probably one of the hallmark symptoms of PTSD, which might result in overprotective behavior of loved ones or paranoia. It is not hard to imagine that somebody, let's say, who has suffered sexual assault, is really, really overprotective, maybe of her children who go out at night with their friends. Where are they? Like, well, who are they with? That kind of stuff. Exaggerated startle response, concentration problems, and sleep disturbance. And the symptoms have to persist for more than 1 month, right? Otherwise, we're talking about a different disorder. Symptoms reduce individual functioning either socially or occupationally. And I remember in psych and diagnostics, I'm sure you guys had to do that as well. You had to like, you go through different case studies and you say how they reduce the functioning socially, occupationally of the whoever person is in the case study. The symptoms should not be due to medication, substance use, or illness. And there are two specifiers that PTSD kind of has in the latest DSM, and those are depersonalization. Depersonalization is very, very interesting. I'm going to talk more about this when I talk about rape survivors in a minute. But I've talked to many, many rape survivors who describe it in detail. It is described. Basically as whenever like the trauma was happening to you, the rape, the sexual assault, whatever it is, like one lady I remember told me it was like her, she was at the ceiling and she was watching the bed from above. Some people say like, like you were not there, like you're in the corner of the room. And also the second specifier is derealization. That also I've seen, but a little bit less with rape survivors. So that is when they think like it was not happening to them. It's not real. Like again, this is not me. It's somebody else. Um, and the images become blurred and unreal. And remember, PTSD may be delayed by 6 months or so. Then we talk about delayed onset PTSD. I already talked about it. It's when people try to like avoid basically dealing with the trauma, completely ignore it, employ those defense mechanisms that Freud talked about. And does not apply to children under 6 years old. They have their own kind of diagnostic criteria that I'm going to talk about at the end of the chapter. Then there is complex PTSD. So I already mentioned many, many times my favorite book, The Body Keeps the Score. And in it, the psychiatrist, Dr. Van der Kolk, also talks about how PTSD should be more than one diagnosis. There should be like type 1 and type 2, or PTSD and complex PTSD. So, him and others have been working for many, many years to try to basically make this a diagnosis. But it is still not in the current DSM, as you guys probably realize. And the reason why that is because for some reason there's like a lot of resistance to it. A lot of people think that like PTSD should be one disorder and that should be it. But he thinks that it should be called disorders of extreme stress not otherwise specified, or again, type 2 PTSD. He's okay with both of those. If you are going to talk about complex PTSD, then you are basically talking about disorders of extreme stress that go on for a long period of time. So, concentration camp survivors. Obviously, that did not last 1 day. It did not last 2 days. It was not a single trauma event. It lasted for many, many months and sometimes years, depending on when you basically enter the concentration camp, or a lot of times they got switched between different concentration camps. Survivors of prolonged abuse, Van der Kolk and a lot of the other trauma experts also think should be diagnosed with complex PTSD because it's not just one trauma event, it is prolonged. And combat veterans, a lot of times he thinks they qualify for complex PTSD, especially if you've been on like multiple tours and you're dealing with like many different traumas. So, like I already said, it results from exposure to a prolonged or repeated, severely traumatizing event. And it has three cardinal symptoms. It is somatization, dissociation, and dysregulation. So, somatization is physical problems, associated pain, and functional limitations. Dissociation is kind of what I was talking about with rape survivors before. Personality split between one component that attempts to function in the everyday world and one that is stuck in the trauma. And dysregulation is alteration of impulse control, consciousness, self-perception, and system meaning, and others. So again, those PTSD experts tend to believe that complex PTSD tends to be much more pernicious, much harder to treat, almost like impossible to treat, than the regular PTSD disorder, which is, by the way, also really, really, really hard to treat. And again, this is what is in your book. It does relate to the language Van der Kolk and the others use. Basically, the authors of our book talk about type 1 trauma, which is the sudden and distinct traumatic experience, versus type 2 trauma, basically complex PTSD, the repeated traumatic events, which, like I said, a lot of times tend to have a really, 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 really kind of negative impact and make it very hard for treatment. Okay. Then the book switches and talks about conflicting diagnosis. So the thing about it is, one of the hallmarks of PTSD is that it is often comorbid, particularly with alcohol abuse, but also with anxiety disorders, depressive symptoms, and other substance use disorders. I feel like that is something a lot of us understand. And we basically know that no matter the primary diagnosis, assessment in crisis intervention should always attempt to determine if there has been prior exposure to trauma. So again, the client might come with an alcohol use disorder or something else. They might be addicted to like a cocaine or whatever it is. But the underlying problem might be PTSD. So again, we're going to talk about assessment later on. The author of the book, basically make the very, very, very kind of empathetic, they emphasize that you should always assess for PTSD. Then they talk about something that I think bears repeating. I've mentioned it already, but societal perceptions. Again, when you read different books and when you realize how long it took for us as a society to kind of recognize trauma and to recognize that that is something that affects people, um, it really is kind of hard to understand. So the authors of the book make the point that our society historically has not recognized being a victim of trauma as the equivalent of being mentally ill. So it's almost like if you have schizophrenia, that is a serious disorder. But if you have PTSD, like, are you really, really, really doing everything in your power to deal with that yourself? And of course, veterans were thought to have pre-existing psychopathology or character disorder, like I already mentioned. Um, if they have trouble readjusting, re-entering society after deployment, the thinking was what was wrong with them to not be able to do this. And there is a very, very, very interesting kind of segment of the book when they talk about that Vietnam vet that is mentioned throughout the chapter and how he actually had a father who was a combat veteran himself, and he was in the Second World War. And they made the point that if you have a father, a relative that was in a previous war, actually PTSD might be worse for you because not only you deal with like societal disapproval, but then the disapproval of your family member who might be saying like, "Why did it? I'm fine. Why are you struggling?" And women who are victims of domestic violence were often thought to have a masochistic personality. That's very, very, very well recorded. A lot of times, like I said, we're still kind of dealing with that. The thinking of people is, well, why are they leaving? It's not a good situation. I wouldn't stay in that situation. Why are those people still in that relationship that is abusive? There is very, very, very little understanding that it's very, very kind of hard for some women to leave. And the majority of them do, right? About two-thirds of women in abusive relationships leave, only a third stay. But then there are many, many reasons why they stay, right? And none of those reasons are masochistic personality. It might be they feel like they don't have a place to go. A lot of shelters don't accept, especially if they have a son that's a little bit older. The abuser had made them believe that basically they won't be able to find a job, they won't be able to find a place that he would take the kids away from them, and they might not have any financial resources, they don't have any social support. So again, they have developed this learned helplessness where they feel like nothing they do matters, like they cannot do it. Again, there are many, many reasons why women stay. But unfortunately, a lot of those have been historically misunderstood by society. So we are coming on to the discussion of another book that I absolutely love. And that one is also mentioned in our textbook. It looks like this is Judy Herman's book, Trauma and Recovery. That one is particularly focused on survivors of sexual assault and domestic violence. There are many, many good books on the subject. That one is one of the better ones. It is very kind of, we had to read it in grad school. It was a required read. I've had it ever since then. But I mean, I had to take a lot of classes on domestic violence. And like I said, I think it does provide very, very kind of good information about what it's like to be a victim of rape and sexual assault and domestic violence. So I already mentioned that every single state has a different definition of rape. Usually they try to like get around that by charging people with aggravated sexual assault and things like this, which tends to be more kind of the same throughout states. In North Carolina in particular, the definition of rape is many, many different things, including vaginal intercourse or vaginal penetration. So if there's no vaginal penetration, they don't consider that rape, which you guys see the problem with that on many, many different levels. But going back to trauma and recovery, Judith Herman focuses on the common threads in the survivors of violence. She proposes a three-stage model for recovery. So the first one is establishment of safety. Every time you're a victim of domestic violence, every time you're a victim of assault, you have to get to safety first, right? That is kind of like the first thing that needs to happen. A lot of times women might be able to go to shelters, but sometimes shelters fail in that establishing safety stage. But once the safety has been established, then you have to go through rememberings. And basically, what she means by that is you have to kind of acknowledge what happened. You have to be able to integrate those experiences into your past. And obviously, that's a horrible stage. And obviously, a lot of people struggle. And obviously, you will need professional help. But it also comes with this idea of mourning. So you kind of mourn your previous self, what happened to you, but you try to integrate everything and kind of remerge a different person. And the last stage is reconnection, which basically that is what happened to me. That is part of my past. But I'm going to be a different person. That's what kind of should look like for a survivor of domestic violence. Again, the second stage tends to be the most psychologically taxing to most people, and sometimes the one that people just cannot deal with. Judith Herman, in addition to all the other trauma specialists, also distinguishes between single impact and prolonged trauma. As a matter of fact, one of the first sentences in the book is that it doesn't matter who you are, if you face severe trauma, you will develop PTSD. So basically, even the most agreeable person, like you're very resilient, you face severe trauma and you face it for a long period of time, that will basically affect you. And she also talks about how this prolonged trauma, she talks about complex post-traumatic stress disorder, that's what she calls it. Again, it's not an official diagnosis yet, so different theorists have different names for it. Often involves relational issues like inability to trust and self-hatred. And Herman emphasizes that trauma is a social and political event, not just a psychological one, and that the societal context, including implicated bystanders who fail to act, can be a major part of the trauma. So I love that about her book. She basically has a section in the book where she says that like doing nothing is not good enough, right? If you like every single time somebody is abused, especially for a prolonged period of time, there are people who know. There are people who can intervene, and they do nothing. And again, what is our responsibility as human beings, to basically intervene? By the way, just a side note, I always tell that to my students. If you see domestic violence unfold in front of you, like so strangers in Walmart parking lot, all of a sudden like the guy turns on his girlfriend or the girl turns on her boyfriend, and there's like a domestically abusive situation clearly, uh, the first thing you should do is call 911, right? Like a lot of times, basically they train you what to do because you shouldn't just kind of like walk up to them and try to diffuse the situation. You have to know how to diffuse the situation. But a lot of times, even like people who are like very well trained, may not be able to diffuse the situation because there are gonna be like drugs and stuff involved. One time I had like a black eye from like a similar incident for like 3 months. So I was not made to be in any kind of fighting situations. But yes, I tried to intervene with a very, very good, basically I've been in situations like that many times. This time it did not work out. So again, try make sure you call 911. Do not put yourself in any kind of like suspect situation like that, unless you have the training. And like I said, even then, be very careful. All right. Predisposing variables of PTSD. So I just said that Judith Herman says doesn't matter who you are, you can develop PTSD. But there are some things that make you out. I shouldn't say more likely to get it, but there's some things that matter. And they talk about those in your book. I'm gonna put them all up here, oops, and kind of talk about them one by one. So for genetic predispositions, we all know that we all are born with like different nervous system reactivity, right? It is tied to a lot of different things and how we respond to situation. Some people can be very, very, very kind of hypervigilant, acute in their response to stress, especially if they have previous mental illness, especially if they have anxiety. So obviously, if you have those things, you might be more affected more by trauma. Resilience is a big thing. So I teach positive psychology as well. That's one of the main courses I teach besides the courses on relationships. And resilience is very, very important. I feel like we really, really differ on resilience. And that basically is depending on how you were raised, what you were exposed to. As you can imagine, children from like inner city, urban environment, a lot of times do tend to be more resilient than their like high socioeconomic status counterparts. So resilience is a buffer between you and PTSD. It does matter, but again, you're faced with enough trauma, you will develop PTSD. Then there's some kind of ecological factors like the magnitude and number of trauma. I already talked about that. Basically, every single trauma expert out there agrees that if it's prolonged abuse, if it's a bunch of traumas, it's very, very difficult not to develop PTSD. Personality makeup, again, some of us are high on neuroticism. Remember your big five personality traits. The acronym is OCEAN, openness to experience, conscientiousness, extroversion, agreeableness, and neuroticism. I'm sure your psychology professors talked about it in every single class when you guys were in undergraduate. But neuroticism is basically hostility and anxiety if you're high in neuroticism. So if you're already high in neuroticism and you face trauma, that can definitely be a precipitating factor of PTSD. Chronic child abuse, one of the worst offenders. Children, we're going to talk about them. A lot of times they rely on their abuser for love and protection. So it puts them in a situation that can be very, very, very kind of problematic. And it definitely can be a catalyst for a lot of mental illness. Low socioeconomic status. Basically, you don't have a lot of support, social support or economic support. That's what it comes down to. Lack of education, same vein. Phase of maturational development at onset. Again, kids are really, really, really at a disadvantage when it comes to facing traumas, especially from a loved one. Spiritual beliefs. That one is not talked about a lot, and it's not necessarily religiosity, right? So spiritual beliefs is it could be religiosity, but also are you spiritual in general? So there's a ton of research in positive psychology that that's a buffer between you and PTSD. Some of it is social support, right? So a lot of times people who are spiritual, people who are religious, they might have like their tribe. For example, you might go to church or you might go hiking with friends and stuff like this as part of like your connecting with nature. So that kind of gives you social support, which is a buffer against PTSD. The second thing is there's all this research that believing in something like bigger than yourself also tends to have a protective factor. And social support system, which again tends to be huge. Married people do tend to be, again, tends to be a buffer against PTSD because of that social support that you get. But to sum it up, Greenker and Spiegel, I have them cited in the references because I really, really like that quote from their article. No matter how strong, normal, and stable a person might be, if the stress was sufficient to cross that particular individual's threshold, PTSD might develop. So basically, what this is saying is it doesn't matter who you are. Basically, you are susceptible. None of us are immune to that disorder. Then the book goes and talks about neurophysiological responses and ties PTSD to kind of like a nervous system. So, what happens when you face trauma? And I'm going to talk about that more. So remember, guys, you have the a central nervous system, which is basically your brain and spinal cord, and then you have the peripheral nervous system. Peripheral splits into autonomic and somatic, and the autonomic splits into the sympathetic and the parasympathetic nervous system. And the sympathetic nervous system is basically your trauma response. It's your flight or flight. It is whenever your entire body is turned on. Um, so let's say you're chilling at night, and you see a dark shadow in the window trying to like break in your house and you're by yourself. Your sympathetic nervous system will immediately kick in. And the way you know that your fight or flight response has kicked in is you basically will be like hypervigilant. Skin conductance, pressure, heart rate, you're like hyper aware, you're ready to like fight or flight. So that's basically what the trauma response to your body is. So trauma affects individuals. Neurotransmitters, hormones, cortical areas of the brain, and the nervous system play a large role in PTSD. They make the case in your book, and I wish I talked more about it because there's a lot of like new research that's coming on that. But with prolonged exposure to stress, the brain may continue to function in an elevated emergency state. as if the danger was still present and caused permanent damage. So the thing about the sympathetic nervous system is it cannot stay on for a long periods of time because you guys can imagine you basically are going to have a heart attack. You cannot be in the state of like hypervigilance for a long period of time. Well, that's what PTSD is. And what your body should do is basically let the parasympathetic nervous system take over so you can go back to this like homeostasis state. But because of the trauma, because you're constantly like kind of reliving it, you cannot. So obviously that can cause changes and problems to your brain. One of the results of that is a smaller hippocampus. So remember the hippocampus is part of the midbrain, part of the limbic system, which is your emotional brain. And that one is in charge of converting short-term memory into long-term memory. Smaller hippocampus is basically disrupting your memory consolidation. And a lot of times, trauma survivors play what happened to them on a loop. So they may not necessarily be forming new memories. Again, they have the smaller hippocampus. They're thinking about the trauma that happened to them. And exposure to similar stimuli reactivates the trauma response. So again, you're a victim of sexual assault. You are assaulted in a car park. You go to a car park. You might literally experience the sympathetic nervous system like reactivating in those symptoms again. Bauer and other people talk about this when we're going to talk about treatment of PTSD. Is something that I think is very, very kind of interesting. So he talks about effective state-dependent retention, where he basically says that memories of the traumatic event can only be reached during similar circumstances. So because of that, and you guys will hear me say that later on, whenever we treat PTSD, some theorists believe that you have to get people in that heightened state of anxiety so they can access those memories. Again, that sometimes is controversial. We're going to talk about that. But basically, what Boris is saying is because it was stored in memory, the traumatic memory, and a completely different physiology, you have to get people in that same state of mind again so they can access it. That makes a lot of sense. You guys have heard the studies. That, for example, you have to study in the same kind of state as the one that you're going to be taking the test because of state-dependent memory. So let's say whenever you take the test, you're kind of like mildly anxious. That ideally should be the state where that you study in so you can remember more information. There's also context-dependent memory. We tend to remember things more if we're in the same situation, in the same context. So again, those things are also true when accessing PTSD. So there are some implications for therapy that come with that. And some of them are you cannot just suggest adopting a better, more positive attitude to your client that has PTSD. I feel like that one is obvious. We all know that you cannot just kind of walk it off. Sometimes friends, though, can be like the worst offenders about this. They can tell you struggling with something. They don't know what to say. They feel like they should say something. So their advice is always like, look at all you have, look on the brighter side. Again, adopt a more positive attitude, which, as we know, is not very helpful for PTSD patients because they would just be like, well, you uh, don't know what I've been through. So the neuropathology is worse for children. So then the book talks about incidence, impact, and trauma type. So how many people from the United States will develop PTSD? So the numbers vary, but the book puts it at approximately 10.4% of women and around 5% of men will develop PTSD. I'm gonna talk about this a little bit later. Some other theories have a little bit different numbers. The most interesting kind of slide from, or this information from that slide is the second bullet point, in my opinion, that about 20% of people will experience PTSD after experiencing trauma. So again, what this is saying is obviously the majority of us will not experience PTSD after experiencing trauma, but we already talked about precipitating factors and we already talked about the severity of the trauma, and if it happens more than once, makes it more likely. So who's most likely to develop PTSD, besides all the precipitating factors we already talked about, is teenagers, employees of hazardous occupations, where you see a lot of death or a lot of trauma, victims of severe burns, sexual assault, refugees, and combat veterans. So I feel like we've talked about all of those, but we haven't talked about refugees. We haven't talked about victims of severe burns. Honestly, they're not mentioned that much throughout the chapter. And part of that is there's not a lot of information on refugees. There's not a lot of research on refugees. We all know it's a traumatic experience. You leave everything you know behind and you go to a different country, which a lot of times is not positively kind of um, Inca kind of not happy to see you, a lot of the people there. So it can be trauma on many, many, many different levels and prolonged trauma. Severe burns, same thing. It can be a very prolonged trauma because, as we know, the recovery time for severe burns is long. Uh, so the residual impact of PTSD is it can happen even when someone has excellent coping skills and a positive support system. And on page 154, at least in my edition of the book, there's the example of Chris, and it's a very, very interesting one. I urge you guys to read it. So basically, Chris has a lot going on. He has a supportive family, but still being in the Vietnam conflict and him basically being triggered puts him in a situation where he acts in ways that like he cannot recognize himself. So again, it can happen to anyone, the residual impact. And the importance of trauma type. This to me was very, very kind of interesting. The book talked about how the type of trauma, meaning whether it's man-made or natural disaster, is also very important. And honestly, never thought about it. I know Dr. Webb is part of the Red Cross, basically crisis response unit. So whenever there is a tornado, whenever there is like a um, big hurricane, I'm sure she's talked to you guys about it. They deploy her, the Red Cross deploys her, and she goes and counsels survivors. Well, according to the book, very, very, very few people of natural disasters actually do get PTSD, which I thought was interesting. Um, and part of that is because whenever, let's say, there is a big hurricane and Charlotte gets destroyed, which is like the worst case scenario ever. But in that horrible, horrible scenario, we all would have lost everything. We would have been like, having this like shared experience, and we all would be survivors. And we'll have each other as our support system, which apparently is what makes all the difference. And by contrast, human-made acts of trauma that affect the support system. So we're talking about, again, the Holocaust, kidnappings, incest, sexual assault, school shootings, which we haven't mentioned so far, are most likely to result in post-traumatic stress disorder because you're not only facing trauma, but that trauma kind of basically um, destroys your support system, right? You are kidnapped, you are torn from your support system. You're a survivor of a school shooting. It is your classmate, it is your friend that picked up a gun and kind of came to school and started shooting. So the survivors of that trauma will be like, well, who do I trust now? If that can happen. So the man-made crisis are unpredictable and the trust in the community is shattered. And that's what makes them more susceptible, more likely to produce PTSD symptoms in people. So the book then kind of goes back and talks about what again kickstarted the PTSD research. And as I already said, it all started with the Vietnam War. That's why it's considered the archetype. And even though those folks, the Vietnam vets, were really, really, really struggling, a lot of them were. They did not receive any support from the government until basically, like I already mentioned, a bunch of psychologists and psychiatrists got together and started kind of trying to help them. So the reason why the Vietnam War vets had higher PTSD than other returning veterans, so about 20% of all Vietnam vets got PTSD, which is a really, really high number, was because of different specific reasons to that war. And some of them are hypervigilance. So I feel like that applies to the recent wars in Iraq, Afghanistan as well. But just that started with the Vietnam War. So anything can be like a combat area. Like you always have to be hyper vigilant. So like a child can be like smuggling grenades. You can never trust anyone. You always have to be aware of your surroundings. While before in like the First World War and the Second World War, they had like battle lines, and you only basically face combat when you are on the battle lines. So with the Vietnam War, a lot of times people did not see the purpose of it, right? Basically, there was a lack of goals. No territory was won. Nothing that kind of tangible was produced from the U.S. participating in it. Vietnam vets, when they were soldiers, when they were fighting in Vietnam, they were put in a precarious position where both like the victimizer, right, but also the victim of trauma. So they might hurt someone, they might kill someone being a victimizer, but they might also be hurt themselves. They might see their friends and their loved ones be hurt. So that also kind of played a very, very much a role. Then there's bonding, debriefing, and guilt. So apparently with the Vietnam War, and I did not realize it, you weren't in units, but they'll like send you to the front lines. You have like a year, they'll constantly move you around. So there was no unit cohesion. They've learned from that war. So in like more recent wars, you go as a basically as a unit, you're there with the people with the same people, so you can develop camaraderie and unit cohesion. And that is a buffer against PTSD. One of the biggest ones was civilian adjustment. Apparently, at the time, there was no transition period for returning soldiers. The person who is mentioned throughout our entire book that I keep talking about him, he said that it was a very, very difficult transition for him coming back as a soldier from Vietnam because he was in charge of a big unit, right? He was making a lot of decisions. He was in a leadership role. He was constantly like, in those life or death situations. So he comes back to the United States as still a very young person. They were all deployed basically when they were 18, a lot of the soldiers. So he comes back as a very, very young person with this kind of like experiences under his belt. And he said it was very, very kind of like problematic for him because only menial jobs were available. A, people didn't like Vietnam vets because they were against the war. But B, he didn't really have any kind of like educational experience or something like this you could show for. And so he only could do like, jobs he was not truly interested in. Substance abuse as self-medicating became a huge problem for returning Vietnam vets because, again, they were trying to deal with their trauma. And the attitude towards the war of the American people was mostly negative, especially towards the later, like 2/3 of the war. So the book makes the case that if you were a soldier during the beginning, like months of the war, you actually were very likely to not get PTSD because Americans still supported the war. And when you came back, you faced a completely different attitude than like the soldiers who came back after you. And again, the anti-war sentiment is what probably made this the war that produced the most trauma in returning soldiers than anything else. Because not only did they face that kind of trauma on the battlefield, but then they came back and they were completely unable to kind of reintegrate into American society because American society was judging them for what they had done. How do you deal with hypervigilance? This is kind of like ways to help people who are dealing with PTSD symptoms. So your book talks about different things, and they're all kind of very interesting. The first thing that is mentioned is narrative exposure through journaling. The author of the book makes the case that a lot of times people who suffer from PTSD, who have suffered trauma, don't want to talk about it. Remember, I talked about how avoidance is kind of literally one of the criteria for diagnosing. So the way to kind of go around this sometimes is journaling. Because yes, I may not want to talk about it, but I will be willing to write about it. So one of the very, very helpful things to kind of do as a therapist is to encourage recall through writing, and especially like free association. You don't have to like necessarily tell them what they were writing about, as long as it's about what happened to them. It helps get individuals unstuck. So a lot of times you cannot move on. A lot of times, again, you have trouble reintegrating that memory into your personal narrative. But if you actually write it, it might make it easier. And what it does is it places the terrible memories at a safe psychological distance so the therapist can access them and see how therapy is progressing as well. So I never thought about that, but that also is a very, very kind of useful tool to see how basically how much of the trauma is the person processing. So every single time, I remember when I used to do group counseling, facilitating group counseling for, um, they were domestic violence abusers. They've been to prison, and then they were court mandated to be in this group. Basically, the person who was the actual facilitator, I was like the student co-facilitator at the time, will make them start every single session with them having to say, uh, what happened. Describe the scene of domestic violence that they basically were convicted for. So to me, that was like, I mean, that happened like week after week after week. And at first I was like, okay, like we've heard this, like literally the same thing happens in every single session. But every single time they revisited that memory, like more details came to life. Maybe they were willing to take more responsibility for it, or maybe they saw like a different angle of it. So that also serves kind of revisiting the memory of getting unstuck from it. And Lifton talks about something called animated guilt, which enables the individual to start taking responsibility for past actions and experience personal liberation. And again, this animated guilt was what the main facilitator of the group for domestic violence offenders that I was basically uh, co-facilitating was trying to do. He was trying to get them to admit to what they've done. So, how do we treat PTSD? This is to me, again, some of the more interesting part of the chapter. The main way we treat PTSD is with trauma focused therapy. And it helps to reappraise and reframe the memories, and also helps with like meaning making, global and situational. So they make the case that PTSD disrupts global meaning making, meaning that you get really, really focused on that one specific thing that happened to you. But through trauma focused theory, you can get back to that this global attribution that you have when it comes to meaning making. So that helps with symptoms of PTSD. And those are um, I'm sorry. They're intrusive and repetitive ideation, which is basically visual images triggered by sounds, smells, or tactile cues, which can begin to dominate existence. They can be denial or numbing, which is the emotions of guilt, sadness, anger, and rage that occur as the thoughts continue to intrude into awareness, may lead to self-medication. And what I already said, increased nervous system arousal, where the acoustic startle response causes them to react to stimuli that may hold no threat to them. The person who was described in our book talks about how he was not able to stand the sound of a chopper. Yeah, that produced this increased nervous system arousal because obviously there were a lot of choppers in Vietnam and he associated them with trauma. And also another symptom of PTSD that is discussed in that part of the chapter is dissociation. Again, I already talked about that. They make the point here that the dissociation is possibly the most important long-term predictive variable for PTSD, and it is connected to complex PTSD. Um, and that dissociation can range from emotional numbing, like I'm not feeling anything, I'm not really in pain, I would deny what happened to me, to derealization. It is not real, it's not happening to me. And the problem with dissociation is it splits the memory from conscious awareness, and you really want to reintegrate it into conscious awareness. Otherwise, it will lead to post-traumatic stress disorder. So remember, speaking of conscious awareness, those are Freud's terms that we use in modern psychology today. Remember, he talked about conscious awareness, things that you're aware of, like me talking to you guys right now and coughing, unfortunately, through this entire presentation. And then there's the preconscious, things that you can barely remember, but you can bring into conscious awareness. And then there's the unconscious, things that you are unaware of. So that's what happens when you repress memories. They can go into your unconscious, but you really want them in your conscious awareness for PTSD not to happen. So this is another book that talks about the neuroscience of social connections and kind of how PTSD can be related to that. It is a book I recently got for the department, and I really, really like it. I'm actually reading it right now. It's by Ben Ryan, who is a neuroscientist, one of the more famous one, I would argue, nowadays in the United States. So again, he talks about social support. And he talks about how there is possible discrepancy of reaction based on the type of trauma. So intrafamiliar trauma such as incest is the worst. And I've already talked about that, why that is. So your social support is gone, your trust in people is gone. Um, Basically, your entire narrative may be fractured because of it. Um, and also, Ben Ryan makes the case, and I thought that was very, very interesting, that sometimes social support, people that are part of your social support can turn on the victim if they cannot deal with the trauma. And that I thought was a very, very kind of interesting thing. Because a lot of times we don't have the patience for people. We just cannot like just be there for them. Especially if we've given them advice and they haven't followed it, given them advice, they haven't followed it. Um, so let's say, I'll give you an example. You have a friend, and that friend is, I don't know, has a drug addiction. Okay. So you might have tried to help them. You might have like, told them to stop the drug. Obviously that didn't happen. You might have even like paid for a rehab for them or like try to stage an intervention with their family. And that went nowhere. So a lot of us will get to the point where we'll be like, okay, we're done with that. We're not dealing with them anymore. That's too toxic. But really, what they truly need is for us to just be there in case they need us, if they're able to deal with the situation themselves. So, people who face trauma a lot of times really, 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 really just need social support eventually, even if they're not kind of taking advantage of it at the time. Because spending less time with others can impact the body and mind on a cellular level. So, what happens with people that have faced trauma is, again, their brain might be rewiring because of the trauma, but also it's rewiring. It's changing on the cellular level because no longer people hang out with them. And it is important to remember that our brains are wired for connection. And modern life is challenging those ancient instincts. But nothing challenges it more than trauma, right? You have been sexually assaulted. You don't want to hang out with your friends. And really, like your friends might start avoiding you because maybe, you act paranoid. Maybe you keep talking about it or don't talk about it at all. You don't acknowledge it. But truly, truly, what you need at the time, in addition to therapy and the other things we talked about, is social support, and your friends to be there. Uh, so some of the maladaptive pattern characteristics of PTSD. We talk about things that are really, really, really kind of bad that can happen. So one of them is death imprint. Um, what happens when you have threatened or basically or witness a death is that you develop a clear vision of your own death in very, very kind of concrete terms. Like you are like, let's say you witness somebody being killed. You get the message like that can happen to me. So that a lot of times affects young people, especially teenagers, because up to this time they were basically feeling invulnerable. If you talk to teenagers, they will say like, "If I die," right? Because to them that's not a reality at all. But they witness somebody being murdered, if they're witnesses to a homicide, obviously that all of that is out the window, and that sense of invulnerability is like vanquished, and a lot of times is replaced by anger and rage. Um, Veterans who are exposed to a lot of death, right, in combat zones, a lot of times report that they feel dead inside, right? They almost kind of like incorporated that. Into their identity. And that is one of the reasons why they might engage in risky behaviors. So they feel alive, so they feel something. Sometimes people might do like self-harming behaviors, like cutting, because of the same reason. There's also survivor's guilt, guilt over surviving, not preventing another's death, not having been braver or complaining when others have suffered more. A lot of times, people who have witnessed somebody dying or any kind of trauma um, basically say, "I could have done more," right? You tend to kind of take this attitude of like, what did I do? There wasn't enough. That kind of basically made it happen. There's also desensitization, which is when contradictory emotions within the person may lead to hostile defensive actions or depressive states. And there's estrangements. Those feelings that any future relationships will be insignificant in the greater scheme of things, which leads to isolation and loneliness. And like I already talked about, what they really, really, really need at the time is more social support, more friends, not loneliness and isolation. And the last one is emotional enmeshment. So basically, that is continuous struggle to progress and move forward in life. So almost like an emotional fixation. The book talks a little bit about Iraq and Afghanistan, and kind of how those are different from other wars. So they are predicting that about 11-12% of soldiers will develop or have already developed, because those wars were obviously a while back, PTSD, which is obviously a whole lot lower than Vietnam vets. But there are some kind of risk factors for those wars as well. For example, and I did not realize it, current soldiers have more tours. So when you were sent to Vietnam, apparently you only did a year and then you went back to the United States. They always did it like that. And the same was true for other kind of previous wars. Nowadays, we all probably know people who are veterans. We probably all know somebody who has been in Iraq and Afghanistan, and we know it's not uncommon for those vets to have like 3 or 4 tours. Obviously, you get paid more when you are on tour. A lot of people volunteer for it, or at least the people that I know, my friends. And obviously, the more tours you do, the more you are likely to develop trauma and PTSD. And there's something called the Comprehensive Soldier Fitness Program. nowadays they realize that being in a combat zone is traumatic. It took them long enough, but there's the realization the VA has like is on board with it. So now they try to do this integrated, proactive approach to developing psychological resilience in soldiers, family members, and the Army civilian workforce. So there are different components to this, which I thought was very, very kind of interesting. First, there was the global assessment tool, which assesses psychological fitness confidentially and provides self-help modules. So this one, supposedly you can do completely by yourself. Like you're wondering about your psychological fitness and your resilience. As a soldier who's about to be deployed, you can do this and you can do those modules to make yourself more resilient. They also offer something called Master Resilience Trainer courses. And they also um, have courses for families, which I think is very, very important because I'm sure you guys have heard domestic violence in military families is through the roof. There is a lot of divorce, there's a lot of other problems that military families specifically face. Um, as opposed to like a lot of the other families. So it's good they're actually now paying attention to that and they have those tools. The thing about it is, I have a couple students who one of them works for the Navy, the other one works for the Marine Corps, I think. They became counselors for the Navy or the Marine Corps after graduate school. The military is surprisingly and very, very, very tight-lipped about any kind of psychological issues within the military. So only specific counselors get access to it, can work with families, and I think that can be very, very detrimental because they need all the help they can get. So again, treatment of adults. How do we treat PTSD? I've already kind of touched upon it, but this is like the main section in the book that talks about it. So according to Van der Kolk and his colleagues, there are three main components if you want to treat an adult with PTSD. They have to be able to process and come to terms with the overwhelming experience. They have to be able to control and master their physiological and biological stress reactions and they have to reestablish secure social connections and interpersonal intimacy. And all of those are very, very, very kind of hard to do, and they come with their own unique challenges. So I already said in the beginning of this lecture that if you are basically some kind of crisis situation, you should always assess for PTSD because it could be obscured by some other disorder. And you should always start with a thorough background assessment. So, for example, gender is important. Women are more at risk for PTSD, race, resilience, like I talked, culture, religion, like I already mentioned, protective factor, geographical area, number of incidents, which is very, very important, and prior exposure to trauma. So the way you can do it, the way you can assess is with a structured interview. You can do self-reports and you can do empirically derived scales. And I'm going to talk about those in turn. So according to your book, the structured interview is the best diagnostic tool there is for diagnosing PTSD. It is very, very time consuming. And as you guys know, every time you have a structured interview, you need to have like a licensed psychologist, counselor, therapist to do it. And they charge per hour. And then they have to so a lot of times it's very, very expensive to do as well if you think you have PTSD. The one that is apparently the gold standard is the one that's called CAPS-1, which was developed by Blake in 1990. It stands for Clinician Administered PTSD Scale. I have a link here that links you to the VA. You can request it from the VA, and you can see like they have like all sorts of like different instructions and resources on it. The thing about it is, at the end of this presentation in my PowerPoint, I have different PTSD sites that you guys can use for different resources. So I highly, highly encourage you to go and look at those. So then you can use self-report to assess trauma. And every single time I hear self-report, I'm thinking a questionnaire, but that is not what they mean. they mean a traumagram. Okay. So I've never heard of a traumagram before. And they have one in your textbook. You guys might be able to see it. Let me see if I can find it. One of the basically authors of the book did a traumagram, and it looks like this. So I was looking at this, and I was like, "Oh my goodness! Like, what am I looking at?" Then I tried to like look for videos, so I can give you some resources, guys. But they literally was on one YouTube video on traumograms, two TikToks, and all of them were not good. So what I decided to do is develop my own traumagram. I don't know if you guys can see it, but I will describe it. Because they say this is a very, very useful tool for therapy, even if you're not dealing with clients with PTSD, because everybody has kind of faced trauma and they want to see basically what traumas or trans crises they're still affecting your life, and which ones have you kind of been able to deal with and incorporate into your narrative of the past. So, in order to do a traumagram, you need drawing skills, which I do not have. But basically, there is a y-axis and an x-axis, right? I think that's what those were called. It's been a while since I was in geography. Uh, Geometry. See, I even said it wrong. It definitely has been a while. So on the y-axis is basically the severity of the trauma from 0 to 10. And on the x-axis is years, the years that you face some kind of trauma. Okay. So I will give you an example of the first one I did. Again, I don't know if you guys can see it, but when I was about 12 years old. So this one here in brown, I tried to like color coordinate it. My dog died. Okay. So this was a level 9 trauma, right? It's up here. This is the severity of the trauma. This is up here. Level 9 trauma because I was really, really close to my dog. Like, I was, remember when they say in movies that when the parents get the child a dog, they tell the kid, you're gonna take care of that dog. Well, I actually was taking care of that dog. The dog was mine. It was given to me as a puppy. And I will like feed the dog. The dog's name was Sean. I will feed Sean, walk him. I mean, I was the only one who took care of him, and he was kind of like my baby, my dog. So again, I was about 11 or 12. And I went to the beach, I went on vacation, and he suddenly died. So it was very sudden. There was no prolonged illness. We don't to this day exactly know what happened. But this was the first time my parents were taking care of him. So that's that. And I was like really traumatized. I mean, I was like, I could not sleep for a while. And remember, I'm like a little child. So for a while there, this was like I said, a level 9 event, very, very traumatic. But then as you guys see, I was able to integrate the trauma severity gets lower here as I get a little bit older. And now I'm able to think of my dog in like positive terms, right? I love all the memories I had together. I love that I had that dog. I show my kids pictures of my dog. But again, I'm able now to talk about it. It is not still a trauma for me. It is definitely not a trans crisis because I was able to kind of make sense of what happened. So it moves like with different things here, and I'll be willing to give you that wonderful piece of drawing if you guys are more interested in. But I encourage every single one of you to do the same. Another thing that I have here is this thing in blue was me moving to the United States when I was about 18. I came for college, Limestone College. So that was like, wasn't like terribly traumatic, but still I would say it's a level like, what did I put it like? Oh, I put it like a 6 or 7. Because every single time you go to a different country, it's like a new language. You have to like relearn everything you know, different food, and things like that. But as you guys can see, it goes down pretty quickly because I was able to kind of deal with all the different changes, take it all in stride, and things like that. So again, every single major trauma should come here, and the ones like this pink one that I have that you are still dealing with should kind of go through your life. So again, this is a traumagram. It's a way to assess trauma in your clients, and I highly, highly recommend you look into it. And the third way you can assess trauma is through empirically derived scales. So there are different ones. You can easily Google them, find them online. I think I have in the resources one of the links for them. But it's things like the Mississippi Scale for Combat-Related PTSD, which was developed by Keene, Caddo, and Taylor in 1988. Impact of Event Scale by Horowitz, Wilner, Alvarez have actually used in research. And the Keene scale of the MMPI-2 is also sometimes used to assess trauma. So again, any one of those. They are self-report, and you guys know the MMPI is actually like a Scantron. So always with that is people may lie, people may not know this what kind of like thing they're feeling in. So there's always kind of risk with that. The gold standard in general, with psychology, what we always tell students is use two of those, right? So empirically derived scale and a structured interview, or empirically derived scale and traumagram and an interview, they definitely cover all your bases. Then Brand and Parsons talk about the phases of recovery from PTSD. And that definitely is the next part of the chapter. So they talk about things like emergency or outcry, which is the first stage of recovery. So that one is the fight or flight stage, the activation of the sympathetic nervous system. It lasts as long as the event lasts, right? We talked about that. And the counselor needs to help reduce the anxiety and physical responses associated with the trauma by using techniques such as relaxation training and meditation. I'm going to talk about that in a second. And eventually, flooding, systematic desensitization, and prolonged exposure may be used to create autonomic system arousal. So you may remember flooding, systematic desensitization, and things like this from the learning chapter in your general psychology class. Those are basically classical conditioning terms. I'm going to talk about them in a minute, but it's the way we treat phobias. It works for trauma as well. The second phase is emotional numbing denial, when the survivor protects psychic well-being by burying the experience in subconscious memory. You may remain forever in this stage unless you receive professional intervention. Again, very, very important with PTSD. The therapist needs to use prolonged exposure so a traumatic event can be brought into conscious awareness. So you guys might already notice a theme throughout the entire presentation is you need to be able to access those memories. You need to reintegrate them in your past narrative. And that is kind of the key to it all. And then the third phase of recovery is intrusive repetitive. It's when the client might have nightmares, volatile mood swings, intrusive images, amplified startle response. Pathologists may emerge and the use of defense mechanisms to try to bury the trauma. Remember those defense mechanisms I talked about: repression, denial, you name it. Intervention is often sought during this stage, and the therapist often uses a more psychodynamic, again, that was Freud's theory, approach, actively interpreting what the client says. Then there is a reflective transition phase when the survivor comes to terms with the trauma and confronts the problem. And the therapist, again, may use flooding, prolonged exposure, any kind of fear-evoking stimuli presented continuously as the therapist helps put the missing places in the memory and ferrets out the conditioned stimuli buried in memory, buried in memory. Again, what you're trying to do is break that classical conditioning association. That's what you're trying to do with all of those methods that I'm about to describe. Also, there's thought stopping. I thought that was very, very interesting. But what you're trying to do with thought stopping is you're trying with the help of the therapist to change debilitating, intruding thoughts to self-enhancing ones. So whenever you say something that is debilitating, intrusive, I'm a horrible person, the therapist literally says stop. And then they make you change it with something that's more like a self-enhancing attribution. And the last one is the integration stage. The survivor successfully integrates the trauma with all other past experiences. Again, it's all about integration, restores a sense of continuity to life. And the therapist may use the Gestalt principle, such as the empty chair or any other thing that brings unfinished business into conscious awareness. I don't know if you guys remember the empty chair, the Gestalt. I thought that was the coolest Gestalt thing ever. Whenever you sit across an empty chair, um, in a way to basically talk to someone that's not there right now. So it could be like talking to your grandma that's passed away and you cannot tell her anymore what she meant to you or how much she hurt you. Or it could be a way to talk to somebody who has abused you, right? And obviously not have them in the room with you. So you pretend they're in the empty chair and you tell them everything you need to tell them. So that's a very, very kind of well-established Gestalt technique, and it definitely is sometimes is used in the last phase of recovery. All right, so now we're getting to treatments of adults again. Initiating intervention. So the thing about PTSD that you guys might be aware of is that victims may refuse early intervention, right? A lot of times it's so difficult to talk about the trauma. Um, or sometimes, again, it's guilt. They think that people of good character should be able to cope with traumatic events. And those are two faulty assumptions that often result in delayed onset PTSD. And again, remember, delayed onset PTSD is when you get PTSD 6 months or so after the event. So, acceptance is very, very important. Disclosure is difficult because the events of the trauma may seem horrifying and socially unacceptable. But it is central to the therapeutic process. A counselor has to be able to provide acceptance through things like empathetic listening. Remember your clinical skills from previous classes, owning statements, and things like reflection of feeling. Again, those are the clinical skills that we talked about in previous classes. So this to me was a very interesting part of the chapter, risk of treatment. So what it suggests is that after the initial crisis has passed, the human service worker should communicate clearly the following risks to the client. Um, so I'm sorry, I might be running out of time on Zoom. It gave me a weird message, but I'll keep going until it cuts me off. So after the initial crisis has passed, the human service worker should communicate clearly the following risks to the client. Um, they should know that there are no magical cures. There only might be partial recovery. The intensity of treatment may impact occupations or relationships. It may require weekly therapist appointments and inpatient treatments. The patient may get worse before they get better. They should know that re-experiencing the traumatic event is very, very painful. And after catharsis, the individuals may experience a personality change that might wreak havoc on relationships. That one was very interesting. They basically were saying that sometimes families kind of adapt to the trauma. So you got a returning veteran. You know that sometimes he flies off the handle. And that is your husband. You love him. You find ways to kind of deal with that. But then he gets treatment for PTSD, and you think now he's harder to deal with because his personality has changed. So people who are getting treatment for PTSD should be aware of that. It is difficult to give up thoughts or revenge related to the trauma. That one was something also I never thought about. But once you remember something that was done to you, especially, and you reintegrate it into your past narrative, it will be indeed very, very difficult not to think about revenge and kind of trying to get back at the person who hurt you. Uh, there is pain associated with accepting the world as it is. So now you realize you live in a world that's not safe. There are people out there that can hurt you or hurt the ones you love. So obviously that is not a comforting thought. And it is difficult to accept one's own limitations. That speaks to the fact that, I mean, sometimes there's only so much you can do, and you kind of have to live with that. So the multiphasic, multimodal treatment of adults with PTSD is, like I said, the gold standard is trauma-focused cognitive behavioral therapy. So it is the most effective to reduce symptoms. It focuses directly on the memories, reminders, stimuli and events of the trauma. It tries to erase and expose the memories and integrate them into the narrative of the past. It also replaces the survivor's negative attributions about themselves with positive ones. So a couple things about that. So first of all, in order to kind of do trauma-focused behavioral cognitive therapy, you have to turn the autonomic nervous system on, meaning that sympathetic nervous system that's part of it, the fight or flight, has to be on to access those memories. So trauma-focused cognitive behavioral therapy a lot of times has been criticized for being like too painful, too traumatic for people, because they have to be in that state. Second, remember what attributions are. So whenever I went to grad school in psychology, I was told that as long as I use the word attribution, I'll be good to go. So the attributions are things that we use to kind of explain the situation. And prolonged exposure is the fact that trauma rewires the brain and returns the survivor to conditions that closely approximate the trauma. And imaginal exposure, the client listens to the therapist, recreate the situation or the trauma or gradual in vivo exposure. It serves to change the associations in the brain, and the client eventually becomes desensitized to the previously fear-inducing stimuli. So what prolonged exposure is whatever you are traumatized by, afraid of, you get a lot of it. It's also sometimes called flooding. They talk about this in the next slides. It is a learning, basically term. We use it to deal with phobias. We use it to deal with traumas. Um, it has been heavily criticized because imagine being traumatized by, I don't know, school shootings. And then you're exposed to like all sorts of information about school shootings until like, you get desensitized to it. Obviously, that can be very, very traumatic for people. And sometimes it leads to kind of physical problems. So there's also cognitive processing therapy, which is abbreviated as CPT. And that one was developed by Patricia Razek to treat PTSD and sexual assault victims. It works for groups and individual sessions, so I can work with group therapy as well. What happens here is homework is assigned to monitor daily thoughts and feelings. Um, the interesting part to me is that Patricia Razek conceptualizes PTSD as a disorder of non-recovery. So what you can do is manage it. What you can do is kind of like deal with it, but not necessarily something you recover from. And Patricia Razek has identified three phases of treatment, and those are education about the procedure. There's a lot of psychoeducation in that approach. There's trauma processing. There is learning. The third one is learning how to disrupt the flow of negative feedback individuals generate for themselves. So it's more like every single time you feel like you deserved it, every single time you feel like you're a bad person, every single time you feel like that happened to you for a reason, you learn to kind of disrupt those thoughts and replace them with different ones. And the overall goal is to create a new narrative about the event. Now you're a survivor. Now you're someone that kind of has emerged from this event versus something that happened to and is defined by it. So the other approaches to deal and treat a PTSD are stress inoculation, which also has three phases. Also, the first one is psychoeducation. The thing about trauma is you have to understand its effects. You have to understand how it affected you, how it affects the brain. So that's why a lot of those approaches have psychoeducation. There in this one, which I like about it, it has skill acquisition to deal with anxiety. And they have real world testing of the coping skills. So they don't just tell you how to cope with trauma, they put you in real world situations to see how you cope with that trauma. In that part of the chapter, they also talk about telehealth, which I never thought about in relation to PTSD. But they say that because so many people feel like shame and guilt, they have PTSD. Telehealth is kind of perfect because, again, you can talk to someone over the phone, online, and not really be in the same room with them and like experience that severe shame. There's something now that I went and looked at. You guys have the resource right here. I have the link, PTSD Coach Online. So anybody can go in there. It's a free resource and kind of you can get some information, some help with PTSD treatment. Then there's virtual reality. I've read actually quite a few articles about that in relation to therapy and PTSD. It tends to be especially kind of good for veterans because a lot of times they're very, very resistant to getting therapy because part of their image, self-image is they're just tough guys. They don't want to review about themselves, a lot about themselves, but somehow they're very, very okay with virtual reality because there a lot of them are used to playing video games and kind of part of that reality. So Alice and Hoyt did a meta-analysis of VR exposure therapy. Basically, they found it is very, very effective with the trauma therapists. It works on emotional processing and emotional dysregulation by presenting multisensory stimuli targeting everything, the trauma. And there is apparently a game that's called Virtual Iraq. And yes, it is a game, but it's also a therapy game because it basically trains you to be more resilient by being in this VR situation. I know the military uses VR for training too, which again helps because soldiers are already kind of accustomed to it. What I already said is that some critics suggest that the push for trauma-focused CBT to remember the trauma in vivid detail is sometimes harmful if not done correctly or professionally. In the video that I have at the end of this, that is by Van der Kolk, he's the first person to say that a lot of professionals are actually not good at treating trauma. It may do more harm than good, especially because they try to put you in that state of like anxiety. And the VA actually recommends using EMDR as a first order treatment for PTSD because there's no need for vivid recollections. So EMDR, we're going to talk about it in a minute. I have a video on that too. Is another kind of very, very kind of often used therapy approach for PTSD. Some of the other more alternative approaches are mindfulness. Again, going back to positive psychology, I can see how mindfulness can be very, very helpful because the whole idea of mindfulness is non-judgmentally kind of paying attention to everything that's happening to your body, scanning your body. And that's what you want with PTSD. You want to be rooted in the present and want to be able to be kind of not judgmental towards yourself. So I can see how even if people choose out a therapist with their clients, they might want to incorporate mindfulness because I can see how it can be truly helpful. And the idea is that by practicing diffusion, the toxic thoughts that people have about themselves and the trauma start to lose their power. Of course, you can use medication. Psychotropic medication is another way you can treat PTSD. Not us though, not counselors, not therapists, not psychologists, but psychiatrists can basically use some medication. The thing about it is there's really no fixed pharmaceutical regimen for PTSD, and a lot of drugs have been kind of criticized for that because they keep getting prescribed to people with PTSD, but they're not truly effective. The results may vary per the individual. And for example, one drug, fluoxetine, reduces numbing and arousal, but only in clinical trials. It doesn't work in the real world. The majority of clinical guidelines recommend depressants such as Zoloft, Plunestera, and Cymbalta to deal with some PTSD symptoms. But as you guys can imagine, that's not really treating the disorder. They need to see a therapist for that, in addition to the psychotropic medication. And also, there is group treatment. And the group treatment is basically comes in three types. There are debriefing groups. They're short-term, preventative. All the members have just gone through the trauma. This is what just happened to you. Usually, the military does this when people are returning from combat. There are structured therapy groups that use a manualized treatment program to deal with PTSD. They typically last about 12 weeks. Have homework, have psychoeducation. The CPT with rape survivors that I talked about is an example of a structured therapy group. Although, as I said, it works with an individualized treatment as well. And also their support groups. Those are open groups. They're long-term. Members have been exposed to the same kind of trauma at different times. People can come and go whenever they choose to, but they can get social support in that group. AA is obviously an example of a support group, not necessarily for trauma. They're trauma-specific support groups. Um, the whole idea of group treatment started and support groups was started by Lifton and Shatan in 1970, and they started it for veterans. Again, that's around the time of the Vietnam War when psychologists tried to help the Vietnam vets. Support groups usually have focused on emotional adjustment, social involvement, and education. The life adjustment groups help the client readjust to society after accessing and working through the trauma. Those tend to look at things like integrating past experiences, new ways of coping, new life directions, and then there's the family treatment groups. Those are interventions for the client support system, which again, like I've said before, are very, very important. And they tend to deal with a dysfunction in the family as they have adapted to the PTSD of the client and may have trouble readjusting after the client gets therapy for the PTSD. All right, there is the EMDR, which again was to me very, very wild. This is the video that I hope everybody watches. It's on YouTube. It's by EMDR Society. But just some kind of little information about EMDR is I think it's wild, it works. But I know a lot of therapists that say it does work. It doesn't work for everyone. It depends on the person. It does tend to be controversial. It was developed by Shapiro in 1989, and since then, she had created like different types of EMDRs for like children and things like this. It obviously is not intrusive. It doesn't need you to turn on your sympathetic nervous system for it to work. You can just kind of sit there, sit back and relax. It is a basic technique. Where the client visualizes a trauma or experiences thoughts and feelings related to the trauma. So it's not completely relaxing, but like I said, not like the trauma focused CBT. And as you guys know, they watch the therapist's finger as it moves rapidly back and forth in front of the client's face. So whenever we read about EMDR, it sounds very, very basic, right? It sounds like anybody can do it. Obviously not. There's like quite a bit of training for it. And you should not attempt it unless you literally have been trained for it. Uh, so the thing about it is, you have to do history taking and treatment planning first because not every single trauma EMDR is appropriate for. But that's why you should do a traumagram, right? Going back to my masterpiece, because you can look at the trauma people have throughout their lives, how long it has lasted, and whether they're like over it or not. And then you can identify the traumas that EMDR is appropriate for. This is literally how you're going to start the conversation. You go to the client, if you can do EMDR, and you say like, "Oh, I see there's still like three traumas that you're trying to process. Can we talk more about this and see if EMDR is appropriate for any of them?" Then you have to do preparation. You have to tell the client what is going to happen, their safety procedures, what are the effects expected. It doesn't just happen once. Shapiro proposes that EMDR treats traumatic memory by requiring the client to maintain an awareness, either an image, negative self-statement, or the physical anxiety response, which again is the one that's probably the most traumatic. Um, so what happens is the client generates the scene and visually tracks the therapist's finger, which results eventually in desensitization. But again, not a one trial thing. It keeps a lot of times you have to do it over and over and over again. Um, and it doesn't end there. Then you have to like install a new positive cognition of the event. Um, After like EMDR, in the process of EMDR, like you've done it once, you've done it twice, then Shapiro and other people who can do it will ask you to do a body scan, which I thought was very interesting because we do that in yoga. So you have to uncover a physical location of the anxiety. So let's say I feel like this pressure, this tension in my neck, which kind of gives it like more like a physical location every single time I think about the trauma. And then you do EMDR again. You track the finger after you've identified the physical location. And when no new events or negative cognitions are elicited, the EMDR procedure is terminated. Again, it can last a while. And at each session, an assessment is made of the previous targets. Like, I mean, how are they dealing with that trauma? Is it still problematic? Are they doing their traumograms? So you have to keep doing that reevaluation. So to finish the chapter very, very briefly, I know I've been talking for a while and coughing during this presentation, but they talk about PTSD in children. And like I said, this is a whole new ball game in general. If you are going to be working with children, you need to be trained in a lot of those things. The numbers that they give are pretty serious. At least half of the children, 30 to 50%, will experience at least one traumatic event by the age of 18. Um, we did a survey at Gardner Webb. One of the students was one of the professors was doing her PhD in, I think, community psychology. She was an English professor. And she did this phenomenological study with incoming freshmen. How many of our incoming freshmen have actually witnessed a homicide or some kind of violent offense? And it was a very, very, very surprising number of our high number of incoming students who have witnessed it. So again, I believe those statistics. A lot of children, unfortunately, will face at least some kind of traumatic event, especially now that we live in this age of school shootings and everything else. Girls are more likely to develop PTSD. About 3 to 16% of girls and 1 to 6% of boys will develop PTSD. So the type of trauma will impact the likelihood of developing PTSD. Obviously, if you see a parent killed or sexually assaulted, you're basically guaranteed PTSD. That is super traumatic for any child to experience. Um, Same is true if the child is sexually assaulted themselves, herself or himself, especially if it's a parent or a loved one. Again, it's really, really hard for them to kind of reintegrate those feelings of that person's hurting me, but I'm relying on that person and I love that person. 77% if the child witnesses a school shooting, which is really, really troubling, especially considering how many school shootings there are nowadays. I feel like they don't even make a big deal of them on the news anymore because it happens so often. And 35% of the child witnesses violence in their neighborhood. And again, unfortunately, a lot of the children in the United States are exposed to some kind of violence in their neighborhood. So, how do we do the assessment? How do we diagnose? What are the diagnostic criteria for children under six? So, A is the exposure to the event, just like adults, you directly experience it, or basically indirectly, it happens to a family member. Um, and then there's the intrusion symptoms, at least one. Recurrent, involuntary, intrusive, distressing memories. Again, the distressing dreams, the nightmares, the kids that develop, sometimes in the form of night terrors. There's also something that's specific to children in criterion B, which is trauma-specific reenactment in play. Sometimes I've seen this in foster care children, whenever they're placed after some kind of problem at home. Sometimes through their play, they try to like reenact what has happened to them. Um, Another criterion under B is intense or prolonged psychological distress, where exposed to cues that symbolize or resemble an aspect of the trauma, and a marked physiological reactivity to cues that symbolize resemble an aspect of the trauma. And again, you have to have at least one of those to be diagnosed with PTSD. Then we have criterion C, which is avoidance. Again, just like adults for the most part, avoidance of activities or places or people that remind you, increased frequency of negative emotional states, socially withdrawn behavior, persistent inability to experience positive emotions, and diminished interest in just activities they used to like love before. Then there's criterion D. You have to have at least two of those, which is irritable behavior and angry outbursts, including temper tantrums for kids, obviously. Then there's hypervigilance, exaggerated startle response. They basically freak out whenever they hear a noise or whatever it is. Difficulty with concentration, which teachers might notice at school, sleep disturbances, or risky or destructive behavior. And again, criterion E, the disturbance lasts for more than 1 month, again, to be classified as PTSD. The disturbance causes clinically significant distress or impairment, and the symptoms cannot be attributed to another medical condition or substance use. So the thing about kids is the way PTSD shows up in kids might be different than the way it shows up in adults, which I know makes logical sense to you guys. But in addition to the generalized nightmares, which adults also get, but might look different for children, they might like see monsters everywhere. They have this like sense of foreshortened future, meaning like they might be like really, really young, but they sound very old and wise, and they say like, life is not going to go anywhere for them and say things like that. It's very, very kind of dark things. Also, they may start believing that they can almost have like prophetic abilities. They may see into the future. And again, the future is not looking good. Um, Sometimes they might have like somatic complaints. They actually might start experiencing headaches and stomach aches, especially at school, away from the abuser, away from the trauma. And it might be really, really hard for like the school nurse to tell what is causing those without doing like a PTSD and like trauma assessment. And they may experience disorganized or agitated behaviors, or they may demonstrate regressive behaviors. So again, they might act like they're younger than they are. If they're sexually abused, they might start like wearing pigtails and stuff like this. So again, there are many different ways those symptoms kind of show up in children under 6. So the effects of trauma on children. The thing about trauma is, depending on the age, it really, really affects your attachment. So I'm not going to go into detail with that, but everybody should hopefully remember Bowlby's attachment theory that you guys talk about in different psychology classes. That depending on the way you are raised, the way your parents treat you, whether they can instill a sense of security to you, you can either have like a secure attachment, anxious ambivalent, or avoidant attachment. Um, Obviously, if you face trauma, you're very unlikely to have secure attachment. And that is like basically it tends to be your generalized trust, how you approach all relationships for the rest of your life. Support systems are very important for children. They're very important for adults, but even more so for children. The common comorbid disorders for PTSD in kids are anxiety, somatic problems, depression, panic attacks, rage reactions, and phobias. Um, it could be magnified by threats to caregivers and loss of loved ones. And as we know, after effects can will last well into adulthood. So just like with adults, some psychologists have said that PTSD in kids should have a type 1 or type 2. Type 1, just like with adults, is when there's a sudden distinct traumatic experience, like one school shootings, one sexual assault, one you witness, I don't know, homicide. Unfortunately, that can show up in kids is they can have like fully detailed, etched in memories, retrospective rumination, they keep thinking about it, misperceptions and mistiming of the event, thinking like it lasted way longer, it just happened, that kind of stuff. They can't place it in time. That can lead to nightmares, sense of foreshortened future, and so forth. Type 2 is kind of like, the complex PTSD that other therapists have talked about, which is when the psyche develops defense mechanisms to ward off the repeated assault. And it can show up in things like denial, psyche numbing repression. So, like, you don't remember it, you don't deal with it, but you might recover those memories in your like 20s or 30s. Um, Disassociation, what I talked about, you watching yourself like you're watching a movie or you're like at the ceiling looking down on you. Identification with the aggressor is a big one, especially for kids. Um, because they can see that person has all the power, right? They want that power, they crave all that power, they might love this person, saying that they might grow up to become an aggressor themselves, or they might grow up to turn that aggression towards themselves. So again, self-mutilation, cutting, depression, low self-esteem, a history of being in bad relationships, etc. So intervention strategies for kids are again similar to adults. There is interviewing, just talking about it helps children. There's a trauma symptoms checklist for young children. There's something called a clinician administered PTSD scale for children, which is called basically abbreviated as CAPS C. There's projective techniques. I talk a lot about that in all my classes. But basically, kids a lot of times have trouble verbalizing when somebody has hurt them, especially if they feel like that might basically reflect back on their loved ones. Maybe the aggressor told them that they're gonna kill their mom if they say something. But they might be willing to like draw it, or if they draw themselves, let's say they draw themselves with their family, and their father is sexually abusing them, the way they draw themselves might be like they're further away from the family in black, they're small compared to everybody else, and so forth and so on. So the draw portion is definitely a projective technique that is often used with kids, as opposed to an objective technique like self-report tests. And of course, therapy, they use EMDR with children too, but there are different like modifications. For example, for small children, you use puppets on the fingers and it's shorter. You use CPT and CBT as well. But a lot of times flooding is not recommended with kids. Remember, flooding was whenever you expose to like a lot of the trauma-inducing stimuli, and obviously that can like really, really traumatize kids. And play therapy is also recommended with kids. Um, Basically, in the book they say do not use non-directive play because restitutive play, reenactive the trauma is common and harmful. So you have to direct play therapy. So how do we move beyond the drum? How do we get all of that I've been talking about in this presentation? What you want is something called post-traumatic growth. And basically, you have to understand the negative aspects of PTSD. You have to learn to gain emotional regulation. You have to have constructive self-disclosure. You have to create a trauma narrative that supports positive personality change, and you have to try to begin to see the trauma as a positive life transforming experience. But the only way to do it, like I already mentioned, is you have to be able to integrate what happened to you with your past events. You have to face it. So here are the videos that I included as part of this presentation. I just didn't play it because A, I felt like I was talking long enough, but B, sometimes Zoom messes up the quality of the video. So please go ahead and watch it. This is the video on the Buddy Keeps the Score, and it is Bessel van der Kolk talking about his book and kind of little things about it. I highly, highly recommend you reading the book. These are the resources. There are other resources out there that I think you guys should check out. But things like the International Society for Traumatic Stress Studies, the National Center for PTSD, the Sidron Foundation has all sorts of education, advocacy, and research to benefit people who are suffering from PTSD and counselors. Obviously, the American Counseling Association has a ton. The American Psychiatric Association, the American Psychological Association has a lot too. And here are my references. Thank you so much for you guys listening. I again want to apologize for being sick through this entire presentation, but hopefully my voice was it's better than it was 2 days ago. That's why I decided to do it today. I did not have a voice 2 days ago, and I might not have a voice tomorrow. So I got it over with, but I really, really was excited about the topic. I love sharing this stuff with you guys, and I hope you learned something. Have a great day.